know you by your first and last name.
Good afternoon, one and all. Welcome to the inaugural CME themed Clear the Clutter in Infertility, organized by Oasis Fertility team. I am Dr. Vijay Lakshmi, Clinical Head and Fertility Specialist at Oasis Fertility Kurnool, and I am excited to be your host for this session. Before we start our meeting, I would request everybody to put their mobile on silent during the sessions and to occupy the flight seats. I'm grateful to Dr. Durga Madam, Dr. Krishna Chaitanya sir, Mr. Sudhakar Jadhav for imbibing me into Oasis family and providing state-of-art infertility treatment facility to Rayalaseema region. Well, to give you an overview of the prevalence of fertility, nearly 10 to 15% of married couples in India, they come under the shadow of infertility issues that translate to 30 million couples, and out of which only 1% of the couple come forward to get themselves treated. This is because the low awareness levels and the myth that the success rate in IVF or fertility treatment is very low. It is estimated that while female factor accounts for 40%, infertility attributable to male factor is also in the rise, and it also constitutes 40%. In India, the general notion is that, or myth is that, infertility clinics are meant only for treating women. The entire male infertility gamut is just ignored. We at Oasis offer all services and treatments for fertility under one roof and have recently started a dedicated arm of male fertility treatment under the brand called Life. At Oasis Fertility, we are proud to share that in the last 13 years of our journey, we have built one of the most respected institutions in the field of reproductive medicine in India and have helped over 60,000 couples to achieve their dream of parenthood. At Oasis, we pride ourselves about impeccable standards we maintain in your IVF lab, which is an advanced lab. The lab is crucial for the treatments offered at our center, and we ensure that highest level of quality is maintained here. Our lab is one of the very few labs in India that has proper total quality management in place, which optimizes the results of AR. We are one of the first to provide advanced services like pre-implantation genetic testing, IVM, microtissue, vitrification, fertility preservation. The objective of conducting a CME is to train the clinicians across from the city by the way of interactive session on the latest treatment trends and the next generation upcoming technologies. At the end of it, we expect the participants to get empowered with knowledge and recent updates on fertility treatment aspects so that they can start treating more of infertile couples. So kindly sit back and relax, and we hope that the sessions will be liked by you. Before we start on the session, as a customary, we would like to kindle the light of joy. They say that while the prayers go up, the blessings come down. May I request today's dignitaries, Dr. Durga ma'am, Dr. Krishna Chaitanya sir, Dr. Venkatamana sir, Dr. Radha Lakshmi ma'am, and Dr. Rajshekhar sir to kindly come forward to light the lamp and inaugurate the session. Yes, sir. Thank you, ma'am. Thank you, sir. In line with recent developments seen in Kurnool OBG Society, we would like to congratulate new office bearers and felicitate them. I request Dr. Venkatramana sir, our new KOGS president, to please come over the dais.
Sir.
I request Dr. Durga ma'am to come and felicitate Dr. Venkatramana sir. Thank you, sir. Thank you, ma'am. I request Dr. Radha Lakshmi ma'am, our Honorable Secretary Foxy, to come over the dais. I request Dr. Krishna Chaitanya to come and felicitate Dr. Radha Lakshmi ma'am. I request our treasurer, Foxy treasurer, Dr. Mamta, to please come over the dais. I request Mr. Sudhakar Jadhav to please come and felicitate her. Thank you, Dr. Mamta. Thank you, Mr. Sudhakar. Before we move on to our scientific session, I would request Mr. Sudhakar Jadhav, who is our Chief Operating Officer for Oasis Fertility, to speak a few words about the Oasis Fertility journey so far. Over to you, Mr. Sudhakar.
Thank you, Dr. Vijay Lakshmi. Thank you, Dinesh. And as you can see, as we just completed our 12 years and we just got into our 13th year of existence, so that means we are still teenagers in IVF industry. Just to kind of take you through our entire journey, we started way back in 2009 with a single unit at Hyderabad in Banjara Hills. And we have our co-founder, none other than Dr. Durga Jirao, who started this organization way back in 2009, along with Mr. Kiran Gadela. Glad to share that we are an ICMR recognized and ISO 2001 certified organization, and we have been consistently ranked as number one in South India since last 8 years, and we have been the most trusted experts in fertility treatment. These are the picks. In fact, Dr. Durga Ji Rao ma'am is here along with us, and Kiran is our other co-founder. And also we have Dr. Krishna Chaitanya, who is going to speak today in the afternoon. He is our scientific head and clinical embryologist. So this is our core medical team. This is how we look on the India map today. 25 centers. We just inaugurated our 25th center at Kurnool. So we are just taking baby steps, and I'm sure we require your blessings to grow in Kurnool. So we are present in across various states of the country today. This was just a very recent award. We have been, we got this award from Times of India very recently. And this slide is fundamentally our ego feed. We keep getting a lot of awards, and I think for us it's way of life now. I think being very, very fundamental, we are a very, very patient-centric organization. For us, I think the most important person on the floor is the couple, the patient whom we treat. And there, I think, in fact, there's absolutely no compromise when it comes to the patient treatments, right? And as it goes with the values and our ethos, along with Dr. Durga ma'am and every other clinical team member here, we strive very hard to give a biological child to the couple who is visiting Oasis Fertility. And I think we are not in a rat race to be a number one or a number two, but we wanted to be the most respected fertility enterprise in IVF space. So that's what is our aim fundamentally. These are our 5 core values, and then we have extended personality as well. We are very, very compassionate, being competent. All our treatments are very, very customized. The entire treatment files or the patients are, the treatments are kept in confidential, and we are very, very careful while doing the treatments. That's where our electronic witnessing system comes into place. I think the extension of our values is our credibility fundamentally. I think for us, credibility is more important than commerce. This particular slide talks about the overall numbers which we do on an annual basis. We do close to about 15,000 IVF cycles, 20,000 IUI cycles, and so far we have treated more than 50,000 happy families. When we speak about our collective experience, clinical collective experience is more than 300 years, and our success rates, which I'm sure Durga ma'am and Dr. Krishna will be speaking more about it in the afternoon today. They are well above the benchmarks compared to the global standards. And we have dedicated embryologists all across each one of our centers, and we don't do batching at all. Right? From a quality perspective, we are an NABH certified organization. Some of our centers are QA accredited, and our aim is to kind of complete all 25 centers with QAI accreditation. And we are a member of ASRM and FOXY wherever we operate. All our labs are state-of-the-art labs. We have class 10,000 environment in each one of our lab. We use consumables which are MEA tested for toxicity, and we have centralized AHUs with HEPA filter in each one of our labs. These are all wide spectrum of the services which we provide. I would like to focus on 2 points here. I think PGTA and PGTM is something which we have been doing in highest numbers compared to any other player in the country today. And micro TC, I mean, that's what we do in our Andro Life. That's our male fertility clinic. And we have been doing largest number of micro TC surgeries here. And of course, IVM. Dr. Durga is one of the pioneers who keep doing IVM in the country today. Quickly rushing through this slide, a success rate well above the benchmarks of global standards. We assure that whenever the patient comes from your side, we send them back because we are just a fertility clinic. We don't do obs and gynae at all. It's a daycare clinic completely. We just treat the patient, And once the patient conceives, we send them back to the referral gynecologist. So rest assured that the patient would definitely coming back to you. We have a very smart and intelligent system called ARTIS, where the entire treatment journey, the entire journey of the patient is captured right from the first phone call till the couple the woman actually delivers the baby. So the entire treatment is actually covered in our ARTIS, which is a system which we use in Oasis. I think Dr. Vijayalakshmi briefly spoke about AndroLife, which is a dedicated male fertility clinics which we operate. I'm sure you'll agree with me that today infertility is just not female problem, but it is also a male perspective, right? I mean, 50% of the issues actually happens with male. That's where we run AndroLife in each one of our clinics across the country. Well, this is one of our new initiatives. It is like a Google for all IVF patients. They can come here and they can, seek all the information pertaining to IVF. During COVID, I think we were very, very resilient. We started this innovation called IVF at home. Not everything can be done at home, but at least 60-70% of the work was done at home in terms of giving injections to the patients. Right. Talking about giving back to the society, we have Amulya, which is our CSR initiative. And glad to share that if you have any deserving patient who is very, very poor, we keep getting patients when they are basically maids or, auto rickshaw fellows, we still give them a free IVF treatment to them. So I would request if you have any poor patient, deserving patients, then kindly send them to us. We'll be happy to help you here. Last but not the least, I think this is one of the passion and for not only for Dr. Durga, for everybody here. We run an academic institute called Oshram, where we provide, we also have FNB seats, 2 FNB seats, and currently we have about 12 students who are going through their FRM, which is a 1-year course. If anybody is interested, kindly, let us know. We'll happy to help you here. With this, this is the last slide. This is our 3 speakers for the afternoon. With this, I would request Dr. Vijayalakshmi to take on from here. Thank you so much.
Thank you, Andy. Thank you, Mr. Sudhakar. Now I call upon the speaker of the event, Dr. Durga Ji Rao, co-founder and medical director of Oasis Fertility. She'll be enlightening us on role of hysteroscopic interventions in ART practice. Do they enhance reproductive outcomes?
Click automatically.
Okay, thank you. So today, rather than going for ovulation induction, PCO, and all of that, because those will be discussed, they are important topics, and we thought it would be more of an interactive discussion on the clinical topics like that. So we left that for the panel discussion. And I chose to speak on a surgical topic because whatever said and done, fertility is basically an amalgamation and a marriage of both medicine as well as surgery. Though with time, the indications for surgery are coming down. Previously, PCO, ovarian drilling, fibroid, myomectomy, endometriosis, cystectomy. Frankly, all of these are being revisited. And the indications, when we are talking about surgical indications in fertility to enhance your success, every year, I think we are reducing one indication by the other. Because for us, what cannot be managed or what cannot be manipulated is ovarian reserve. And whenever we are doing surgeries, the first thing we have to understand, not just in surgery, in medicine together, is do no harm. And what we have understood is in some of these procedures like ovarian drilling or cystectomies, we seem to be doing more harm than good for the patient. So that's the reason as we are progressing, as we understand the implications, and you also have to know that fertility is not a very old science. We are only 45 to 47 years young. So now the data that has been collected is giving us this latest evidence to tell us what would be the best option for the patient. And frankly, what our aim should be is for the couple to have their own genetic child. We are not here to do donors. And frankly, even the government has woken up and has given us so many regulations now, which is actually making the whole concept of donor and surrogacy under the scanner and giving us the right directions to say that who is eligible, how are you going to make it eligible, and more important, how are you making it safe for the donor and the surrogate. Right, so coming back to the discussion today, we wanted to discuss only hysteroscopy. We're not talking about laparoscopy here, hysteroscopy and the interventions and how they are actually improving our outcomes. So again, we thought it would be better rather than going in a lecture manner to actually give you some cases and how we have managed them over the years. The first case is of a woman who's 30 years old, married only for 2.5 years, and she's been trying for 2 years, secondary infertility, but her main complaint has been scanty bleeding during her periods. Every word that the patient says is extremely important. In fact, that one statement can alert you as to what the problem can be. She said she's got regular cycles, but she has spotting only for 2 days. Obstetric history, very important, spontaneous conception, but she miscarried. What was done? A surgical ERPC. See, even a small little thing like a DNC, look at the implications it has on an infertile patient. She's already had 3 cycles of TI, but no other significant history. When we did her 3D ultrasound, frankly, this is what we saw. And if you can, highlight the actual 3D images, we can actually see that the endometrium here is interrupted. So before we did anything, what we did was a hysteroscopy. And as you can see, this is a woman who's just been pregnant once, conceived by herself, and because of a DNC, which was done when she was pregnant, which means in a gravid uterus, the sequelae of the consequences of just a simple procedure like DNC. Your cavity is narrowed, you have adhesions right from the internal os upwards, and only when you are taking away these adhesions are you able to see the ostia. So the fundus is actually clear for her. It is more when you were curating at the lower part, which is much more narrowed in a gravid uterus. When you are curating, you have raw surfaces which have stuck together and caused the adhesions. This was the picture on your left is the pre-adhesions, and this was the relook that we did after 6 weeks of the first surgery. So Asherman syndrome, the risk factors, and this is something that we really need to understand in 2022. Miscarriage curettage is the most common risk factor for Asherman's. Then comes myomectomy, and even in myomectomy, it is multiple myomas. Then comes single myoma, endometrial ablation, uterine compression sutures for PPH, Mullerian duct malformations, and diagnostic curettage. Diagnostic curettage is okay. But when you're doing a DNC in a gravid uterus, that is the most important cause for Asherman's. So nowadays, what is actually advised is not that you should not do DNC for retained products, even if you have products after medical management, which should be your first option. Ideally, it should be done under hysteroscopic control. So under hysteroscopy, you will see the product and you're only going to be removing the product and not doing a blind DNC and actually causing adhesions. Risk factors is curettage after late miscarriages has a higher propensity for Asherman's than early miscarriages. Curettage late postpartum is worse than early postpartum and repeated curetages. Frankly, don't do anything blind when it comes to the uterus. If you have damaged the endometrium, there is no cure. We are talking about PRP, we are talking about so many other manifestations, but frankly, we cannot get back an original endometrium which proliferates like a normal endometrium with whatever interventions you have. So the guidelines for primary prevention of intrauterine adhesions is procedures confined to the endometrium, like polypectomy, lowest risk. And those entering the myometrium or involving opposing surfaces are at a higher risk. What do we mean by that? That when you're doing a DNC in a gravid uterus, you're likely, when you're doing the curettage, because obviously it's retained products, your vigorous curettage is actually removing the basal layer of an endometrium and causing that problem. And when you're doing myomas, intrauterine myomas that you are doing resection for, you should always remember that two fibroids, if they're facing each other, should not be done at the same time. Because you're leaving two raw surfaces that are going to be coming into contact with each other, causing the adhesions. The risk is greater when electrosurgery is used in a non-gravid uterus for a blind versus vision-guided removal in gravid uterus. So even in gravid uterus, what we are saying is that vision, you have hysteroscope nowadays. It's almost like, how scan has become our third arm, hysteroscopy has actually added another dimension to our treatments here. Adhesion barrier following surgery reduced intrauterine adhesions. This is in short term, but it's a level A evidence. Guidelines for diagnosis, again, hysteroscopy is most accurate for diagnosis and investigation of choice when available. HSG and sono HSG are reasonable alternatives, and MRI is actually not to be used for adhesions. That is not going to give you a proper picture as opposed to hysteroscopy. And pointers at surgery, do it at the early proliferative phase, explain possibility of a second look, use ostia as your guiding mark for how far and how lateral to go. Because again, your procedure, like I said, do no harm. Don't make this a point at which your overzealous surgery is going to cause perforations. Consider ultrasound or concomitant laparoscopy in severe cavity obliterated adhesions. Sometimes you might not even see the cavity. You will have to use a guidance either as a transabdominal probe so that you can see that you're not deviating, or even do the procedures ultrasound transrectally if you are not able to get a proper picture. So somebody is actually doing the transrectal ultrasound and giving you the guidance as to how not to perforate and how to stop at the right time. Now, secondary prevention, that was primary prevention. Secondary prevention, adhesions have already formed. How do you stop them from reforming? Use of IUDs, stent or catheter, semi-solid barriers, and all of these reduce adhesions, and it's level A evidence, and limited fertility outcomes. Level B is estrogen with or without progesterone may reduce the recurrence rate, and relook hysteroscopy. Level C is antibiotic therapy. Frankly, now, post-surgery, this is no longer something that we routinely need to do. Post-surgical resection of intrauterine adhesions, inert IUD should be used, not copper or marinas. So what we can do is, in a copper IUD, you remove the copper, that then becomes an inert thing, and you can introduce that and use that as a barrier. Stem cell treatments, the PRPs that we keep talking about, evidence very limited, and it's only for research purposes. So what do we do now? We, after resection, use a gel, an intrauterine adhesion prevention gel, which is hyaluronic acid. And then we can also put an inert IUD and put them on estrogens. So stepwise treatments, you're actually ensuring that you're using all the three modalities because they work differently, and avoid another surgery. Now that was adhesions. Let's look at the second case. Now she's a 25-year-old, but she's been married for very long, and again, secondary infertility. She's been unable to conceive for the last year and a half. If you look at her obstetric history, she's had 2 cesarean sections, but in the first child had died at 7 years of age in an accident. She has only 1 live child. Then she got pregnant, but that was a biochemical pregnancy, and no significant history other than that. On ultrasound, you see a retroverted uterus, but look at the isthmocele. She's had 2 surgeries. She's had 2 cesarean sections. And what we are actually seeing nowadays is not just women with low ovarian reserve, even in their late 20s and early 30s. We are seeing a lot of secondary infertility. That means they've already had a child, but they're having difficulty having the second one, and particularly if they've had a cesarean section. So isthmocele is something that we are so often seeing. And if you probe the history, they will tell you that they have intermenstrual bleeding, foul-smelling discharge, and then even prolonged spotting or bleeding of red-brown discharge. What does that mean? Even after the period, some of the menstrual blood collects in your isthmosele, and that what keeps leaking even after the period. And when you do a scan, very clearly this is mentioned. So because of that, what we did is, and he was azoospermic, so they needed ICSI anyway. So we did ICSI for them. And even during the cycle, and even on a natural cycle, we kept seeing fluid inside the cavity. Because obviously what was collecting in the isthmosele was traveling into the cavity, which means that not all isthmoseles have to be corrected. But isthmoseles giving you this history that we just spoke about and fluid in the cavity is definitely not going to help her conceive, particularly when it's happening at the middle of the cycle. We even gave her treatment with estradiol for her IVF cycle, and we went on to freeze 3 day 5s and 1 day 6. And even during the IVF cycle, we saw that there was fluid. So we went on to do a hysteroscopy for her. And again, in hysteroscopy, the principle remains the same. You first ensure that you're in the right cavity. How do you ensure that? You go and you first look at your ostia. So start from the top, come downwards. So ensure that you're seeing the cavity, you're seeing the ostia, and then slowly as you withdraw the scope, and we went directly with the resectoscope because we have already seen on ultrasound and 3D that there was a isthmosele. If you're not sure, then first do a diagnostic. But because we knew what we were looking at, we knew that this isthmosele with her symptoms that she needed correction, so we went with the resectoscope. And as we are withdrawing, this is the cave that you should not miss. And you would miss this if you're very quick in moving your scope out. So you see the ostia, you see anterior, posterior, you have seen everything. And the first thing that we do is we pull the scope once you come to the lower segment. But if you concentrate at the lower segment is where you see an actual cave where all the fluid was collecting. So what we are actually doing is the inverted V that happens because of lack of proper healing, we make it a gentle U so that there is no sharp corners which can keep the fluid retained there. So what we're actually doing is trying to create a merger between the superior and the inferior borders of the isthmosele. And again, resection is what you can do. You cannot do this with a scissors. So with the scope, what we are trying to do is resect it, but please be very careful because where the cesarean section scar is where your uterines also might be. So if you're not careful as to your extent of the surgery, if you really go deep, first of all, you're going to thin the remaining myometrium that is there at that spot. And not only that, you will be very close to the bladder and the uterines. And at the end of the surgery, what you have to see is you should be able to see the interior of the cavity without any obstruction. Previously, you could not see it because of the V-shaped, and now after the resection of the V and making it a U, you're actually able to see the cavity. Now the left side picture was the isthmosele that was done prior, that was there prior to the surgery, and the right one was post. Now, the third case. This is a young woman, again, 27-year-old, married for 3 years, primary infertility, inability to conceive, had regular cycles. She's had previous failed treatments in terms of timed intercourse. So when we did a scan for her, because everybody routinely has a 3-dimensional scan for us, because we need to evaluate all the parameters of which even the uterine cavity is one of the factors. So when you're doing a 3D ultrasound, you have to see that this is a uterine anomaly. Now it's very, very important to actually understand what uterine anomaly. Why? Because there are different uterine anomalies and the confusion between arcuate, septum and bicornuate is extremely important because the management of each one of these is very, very different. Now, when we are looking at the prevalence of uterine anomalies, in unselected population, it's only 5%, but if you have an infertile woman with a miscarriage, it's 5 times more, almost 25%. Now, ASRM has made it a little easy for us telling you what arcuate, septate, and bicornuate is, and they've given you certain measurements and criteria. And it is only ASRM because ESHRE does not understand the concept of arcuate uterus. So the classification of ESHRE does not give you arcuate. Remember A and A. ASRM gives you arcuate. ESHRE doesn't. So CUME, which was a compilation of experts who got together, including radiologists and gynecologists, actually came up with this concept to make things easier for us. And they gave us specific measurements and only 3 so that we don't get confused. It is the indentation to the myometrial wall thickness. So how much is actually the myometrial wall on the side versus the total myometrial at the indentation? What is the angle of that indentation and what is the depth of that indentation? Frankly, if you had to remember only one of these, remember the depth of indentation. If it's more than 1 centimeter, that's when it is a septum. If it is less than 1 centimeter, it is a arcuate uterus. So the guidelines say there is insufficient evidence to conclude that the uterine septum is associated with infertility. In fact, recently, within the last 6 months to a year, we had the results of the trial, which actually looked at septum, and they very clearly said that we still do not have enough evidence to say that as soon as you see a septum, you need surgery. Please remember that. If it is associated with infertility or it is associated with a miscarriage or a poor obstetric outcomes, yes, you need a septoplasty. But otherwise, we're still not very sure we're improving their outcomes. Now, this is a septum that we had, and like we told you, this was somebody who had such a long septum, and it was definitely more than 1 centimeter. And during the hysteroscopy, we also found that there were polyps inside the cavity. And again, this is one surgery. Previously, we used to use the diathermy. Now, the statements are very clear. In an infertile patient who needs hysteroscopic or therapeutic surgeries, as much as possible, please do not use diathermy, because the extent of the damage is actually going beyond your pathology. So here we are doing the resection, and very important to understand in a septum is you always have to be in the middle of the plane. And with water pressure and with little snips, you will see that it separates quite a bit on its own. So you have to let distension and little snipping help you guide. And it's also very important to understand where to stop. Again, you don't want to, because you never know. The thickness at the indentation point could not be as much as the myometrial thickness elsewhere. So usually what is said is that you look at where your osteas are, and if possible, with the scissors, make a mark there so that you're not going beyond. Because even you keep snipping, you could go beyond what is actually required. So before you start at the bottom, make incisions at the point where you want to stop. And once you get to that stage, you stop. So this was pre-resection, and the second picture is post-resection. Post-procedure, again, because of adhesions, what is possible to try and avoid is Foley's catheter, which we distended with 10 is quite a bit, unless the cavity is very huge. Anything beyond 3 to 5 ml distension can cause a lot of pain. So you'll have to see, based on the size of the cavity, how much distension you can allow her so that she doesn't feel uncomfortable. She was started on estradiol. Foley's was kept for 2 to 3 weeks. And sometimes what we tend to do is we remove the Foley's, and again, after a few days, between 5 to 7 days, we reinsert a Foley and expand it. Why are we doing it? Because the adhesions happen just immediately post. So whenever you're doing intermittent dilatation with the Foley's, you're actually breaking the strands that otherwise would have become much more thicker and more firmer adhesions. Now, this was the septal resection. We showed the picture to you earlier, and this is post-resection 6 weeks. Now, the fourth case. This is a 36-year-old woman, married for 20 years, but being infertile for 12 years and secondary infertility, para 1. And she hasn't been able to conceive for 12 years. When we are really looking at her obstetric histories, 12 years back, she had a spontaneous conception. Abruption, IUD, cesarean was done. And then she went on to have further treatments, which was TIs and IUIs. So what we did is, because of her advanced age and the fact that she's had previous treatments, we went on to do IVF for her. But during the process of IVF, what we found was this, which was a fibroid intracavity. Now, it's very important, again, to understand what needs treatment and what doesn't. Very clear that type 0, 1, 2, and partly 3 should be resected. Anything else, we have to first understand what her history is. If she is a primary infertility with no issues, then it doesn't mean that every fibroid that you see, which is beyond 4 and above, needs surgery. We still do not have that information. But if she's got a history of infertility or she's got a bad obstetric history, which could point out because of the fibroid, then yes, they need surgeries. Now, towards surgeries, what is best is to understand this classification, which is the step W classification. Size, topography, extension of the fibroid, the penetration of the fibroid, and how lateral it is. How do we interpret this? Because of this classification, it actually tells you whether the fibroids that you have diagnosed, and frankly, the best way to diagnose fibroids is again a 3D scan. If you have multiple fibroids and you want fibroid mapping, again, 3D scan. Only if 3D scan is not giving you enough data, that's when you have to rely on an MRI also. And please make it a point that whenever you're taking a woman to surgery, you should always have their radiological and ultrasound pictures. Always review the images before you even put the woman to sleep. Ensure that you're taking proper consent. Ensure that you're telling your patient there might be a relook that is required. Ensure that your diathermies are working before you anesthetize the patient. These are small little things, but they go an extremely long way to ensure that you have the best outcome for the patient. You do not have another opportunity. One surgery should be the last surgery for her. So whatever is there in your control, we should not miss any of these factors. Now, when you're looking at step W, based on the score, that's how you decide on whether the complexity of this surgery is something that you can handle or you need a senior person to handhold you, or whether it should be done hysteroscopically or whether you should also add on a laparoscopic procedure. Pre-operative assessment, like I said, exclude malignancy, predict likely pathology. Please do not think that you're only seeing atypias or malignancies in older women. We have so many youngsters with PCO and other problems in which hyperplasia has led to atypia, and when not treated at the right time has even led to adenocarcinoma. Provide informed consent. Decide appropriate technology. Decide whether resectoscope or morcellation. Step W classification, the importance is it determines the difficulty, determines the choice of hysteroscopic equipment and fluid management, determines whether hysteroscopic morcellation is an option, and the likelihood of a staged procedure, and also the risk of complications. Nowadays, we have, at least when it comes to infertility consultants, we are seeing more complications in hysteroscopic surgeries rather than any other modality of treatment. Why? Because the anesthetist and us, we get into this stage of complacency. What is a hysteroscope? Putting it inside, having a look, resection, out. But what you have to realize is there is a possibility of vasovagal reaction. She can have hypotension. Complications, when we are not very careful, can lead to the worst and catastrophic complications for a simple thing like hysteroscopy. Because any other surgery, probably in your mind, your anesthetist, your team, and you are prepared. This is a difficult case. All our faculties are, on site. But when we do small procedures like even a DNC and hysteroscopies, 5 minutes, I'm in and out. I'm doing this in between patients. That kind of complacency is the worst thing to happen when you have a woman in the theater. When we're talking about fibroid surgery, this is the most important technique is the resection should be towards you, never away from you. So your resectoscope has to be first positioned behind the fibroid and you are resecting it towards you. You should never push the resectoscope towards the fundus, because if you do not have the right control, you're very likely to perforate. So this again, pre and post. Now the last case, 26-year-old, 7 years of primary infertility, She's had cycles as well. She's had a hysteroscopy, which was normal, and she's had tubal saculations, and her CPT was positive. TB-PCR was also positive, and she had an AMH of 0.8. So when we had a look, we found that she first needed IVF because of her reserve. So we went on, created her embryos. And then when we started her HRT, FET, we found that her endometrium was not really progressing beyond 7.5. We did a transfer wherein we put in embryos, but it was negative. That's when we did a hysteroscopy again, because though the first one was normal, she needed a rehysteroscopy because of the fact that her endometrium was not developing and with a history of tuberculosis. So in this patient, what we attempted was PRP, and our technique of doing PRP is we do not actually inject PRP directly into the subendometrial thing with the distension, because with the water, whatever you have injected actually tendency to come back. So what we do is we use cyst aspiration needles, and we actually make holes right up till the endomyometrial junction all over the fundus and on the lateral anterior and posterior. That's how we do it. And then we remove the fluid distension fluid completely, empty the thing, and then inject the PRP after you mechanically close the external os, so that there is no reflux. And you have to wait, have the patience of actually closing the external os for at least 5 minutes. Wait there, or get your juniors to wait there, because you have to wait for the PRP to actually congeal, become a gel, so that it actually coats the cavity. Because as soon as you inject, there is always going to be a reflux. So close the external os, wait for some time, and only then, come out. And this is what, I'm not saying this is the situation in every woman that we do PRP in. Please understand me. Pathologies can be different. Response to the medications and the treatments also can be different. This woman, we got lucky that, post PRP, that she did develop it. So my point that I'm trying to make is we should do the best, but we cannot promise that we are going to be curing a problem. Sometimes even in ashrams, you might do PRP, you might do stem cells, but that doesn't mean you're going to completely cure her problem. But everything has to be attempted in staged procedures, as well as understand the evidence, so that you can communicate the results to the patient. When you say PRP, they might be under the impression that, I'm not going to have this problem anymore. The next cycle, I'm going to have a beautiful endometrium. May not. And she said, then why did you make me spend money? So you have to discuss the different options with her and the possibility that it might work or might not work. The floor is open if you have any questions for me. Thank you.
Any questions, please?
Good morning, madam. I'm Dr. Rajshekar, gynecologist. After resection of the uterine septum, is it compulsory to keep the uterus?
Is it compulsory to?
Keep the police catheter inside?
Not compulsory. The reason why we did it for this particular woman is, if you noticed, the thickness as well as the size of the septum was so big that we were worried about adhesions. Only in this particular woman. Otherwise, mostly in all septums, if it is a thin septum and the length of the indentation of the septum is not high enough, you can absolutely. But what I would suggest is, Foley's right now is my third option. My first option to reduce intrauterine adhesion is gel. Intrauterine gel for us, at least in the last 1 year, has shown that it reduced the post-procedure adhesions greatly.
I think gel is not available here, madam.
It is.
Kurnool.
Yeah, it will be. If it's in Hyderabad, it should come down.
But we are using police catheter.
It's just that, again, it could be, I'm not saying in everybody, it could be a way of introducing infection. So they have to be on antibiotics for as long as the catheter is there. And again, once that mechanical catheter is gone, The question is, if the healing hasn't happened in those 2 weeks that the catheter is in, it might still have some addition. So a relook might be required in some.
Madam, somebody says 8 days is enough to keep the police catheter inside after resection.
I think, there is no consensus on that, Doc. It could be anything, whatever people, because there is no guideline or a regulation which tells us as to how long it is required to reduce the secondary healing and secondary additions.
Right. Thank you.
Thank you.
Excuse me, madam. My name is Dr. Radhalakshmi. Do you advise laparohysteroscopy for each and every case of infertility of long duration?
No.
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 Thank you.
Excuse me, ma'am. What's the trade name of that gel, madam?
Hyaluron gel. In fact, Dr. Vijay Lakshmi can help you with that detail and the pharmacy vendor. We can organize that.
Excuse me, ma'am. Hello. Yeah.
Hi. Sorry.
I'm Dr. Parvati. I have seen one case as suggested by you, like isthmosil resection. It's converted from B shape to U shape.
Correct.
And what is your experience, ma'am, with success of outcome?
Again, it is you have to first classify, because of lack of time, I didn't actually show you the classification of isthmosil. Like how we have a step W for fibroid, there are certain criteria for us to even understand whether the isthmosil is a hysteroscopic repair or a laparoscopic repair.
Yeah.
So those dimensions are very important. If the residual thickness is more than 3 millimeters to 5 millimeters, then you can do it hysteroscopically. But if it is less, it is best to do a laparoscopic thing. And frankly, laparoscopy results are the best.
Okay.
Obviously, you're completely resecting the area.
Yeah.
And another thing about even the isthmosil repair hysteroscopically is it is not just making it a U shape.
Right.
Now, the base of the isthmosil actually has revascularization.
Right. It should regenerate. Endometrium should regenerate in that place, and the implantation like cervical pregnancy.
See, it is not implantation in the
course.
isthmosil. There is a risk of scar ectopics,
Right.
no doubt about it.
Scar-ectopics.
But even if you do the resection or not, that is the thing.
Right.
See, the problem is implantation doesn't happen when you have the fluid, entering into it. So if you want to completely resect it, and like I said, you have to decide whether it's a laparoscopic approach or a hysteroscopic approach. But if you're doing it hysteroscopically, it's very important that you coagulate the base. See, you're using cutting to make it a U shape, but the base has to also be coagulated.
Okay.
Because revascularization, it might still create, secretions
Right.
and fluid.
So scar ectopic cases you have seen, ma'am, following that?
One. Don't want to repeat that experience, but yeah,
Okay.
madam.
Dr. Durga, when the fibroid is there touching the endometrium, but the patient is a known case of thrombophilia.
Thrombophilia.
Yeah, she has
Right.
repeated abortions.
Right.
Now, is this fibroid important now? Because it is touching the endometrium.
Madam, if it is touching the endometrium, it's a question of whether when you're doing a hysteroscopy, you have actually deflated the cavity or not. Sometimes with the distension of the fluid, you are stretching it. So whether the indentation is actually there or
We
not,
have not done a hysteroscopy, just
You're
scan
talking about-
report. The scan report.
I would still suggest with somebody who's got a history of repeated miscarriages, even though one factor has been identified like thrombophilia, that doesn't mean that, every other factor is negative.
Ruled.
First of all, immunology is a subject that we don't have enough information to actually understand whether there is another aspect of immunology. RPL is a completely different thing. But if you have a pathology like a fibroid, based on the size of the fibroid,
It's a 2 centimeter fibroid.
2 centimeter
touching the
fibroid,
endometrium.
I would say that if on hysteroscopy, because I would definitely do a hysteroscopy for her. In hysteroscopy, again, there are a few pointers here. The thing is, when you are stretching the cavity or you're distending the cavity with fluid, some of these which are just touching or just have got less than 50%, involvement into the cavity, they get pushed back. So before you remove your scope, it's important that you close your inlet, let your outlet, and you watch how the cavity is deflating. During the process of deflation, you might notice some of these fibroids coming into the cavity. Then definitely they'll need to be removed.
Excuse me.
Sure.
One more question, just related to hysteroscopic procedures. Actually, nowadays we are seeing scar ectopy pregnancies more incident, it's rising, no ma'am. So, what is your option? Like, patient is again willing to go for next pregnancy, and your option for take it out like through hysteroscopy method or laparoscopy, and what's the outcome?
Methotrexate. You forgot the main thing,
Yeah,
methotrexate.
methotrexate. But
Exactly.
the
So
stage of
if you can see a cardiac activity, I would first do a intrasac methotrexate.
through hysteroscopy.
Intrascap, not necessarily. Ultrasound nowadays is giving
Yeah,
you such
okay.
good options. And after the beta HCG levels are reduced and your, chorionic villi sampling or the amount of chorionic villi reduces, you can then, if required, do a hysteroscopy. And I would do that later because I don't want bleeding at that procedure. And frankly, if I'm doing a hysteroscopy and there's bleeding, I have to convert to a laparotomy. Correct? So I would avoid those complications by first giving her systemic and topical, methotrexate and then decide on whether hysteroscopy is required. But what's important is what do we do next, which was your next question.
Right.
A scar ectopic which has, there's a possibility it might again
Istomosile
attach.
and all.
Correct. So again, correct the original pathology.
Thank you.
Thank you very much.
Thank you, audience. Thank you, Durga ma'am. That was a phenomenal Durga ma'am. Thank you so much for it. Now it's time for panel discussion on some of the challenging case scenarios which we encounter routinely in our daily day-to-day practice. I request our esteemed panelists, Dr. Durga Rao Madam, Dr. Krishna Chaitanya Sir, Dr. B.T. Sita Madam, and Dr. Aruna Kumari Madam to come and occupy the stage. Ma'am, please come. Sir. Sita Madam. Aruna Kumari Madam. Dr. Durga ma'am, co-founder and medical director. She has overall experience of 26 years and she is a pioneer in research and practice of in vitro maturation treatment and fertility preservation from prestigious McGill University in Canada. Yes, ma'am. Dr. Krishna Chaitanya with overall 15 years of experience and expert in clinical embryology and cryopreservation of gametes. Very passionate about human embryology and constantly researches on innovative approaches to improve the success rates of IVF treatments. And Dr. B.T. Sita Madam, Director of Radhakrishna Hospital and Test Tube Baby Center. She's an infertility specialist with 38 years of vast experience. And Madam is a walking encyclopedia of Kurnool. Dr. Aruna Kumari Madam, she is a Director of Nervati Hospital, Nandyal. She has done her MBBS and DGO from Guntur Medical College. She has done Fellow in Reproductive Medicine, ICOG, Bangalore. She has got Master's Certificate in Reproductive Medicine, Homerton University, NHS. She is a life member of FOXY and ISAR. So now we shall proceed with the panel discussion. The theme being Clear the Clutter, mind-boggling case scenarios. So case 1, she is Mrs. A, 28-year-old, married to Mr. B, 34-year-old, married for 8 years, primary infertility, BMI of 25. She is a known case of PCOS with irregular cycles, 2 to 3 days for every 30 to 90 days, and had been diagnosed with polycystic ovarian morphology on USG with no evidence of clinical or biochemical hyperandrogenemia. She is a hypothyroid on medication since many years. Her previous treatment history, she underwent many ovulation induction and timed intercourse cycles with oral agents and gonadotropins at multiple clinics for 4 years. After that, HSG was done in which bilateral tubes were patent. She then underwent 4 cycles of IUI at a private clinic wherein she was given letrozole for 5 days and urinary FSH for 2 to 3 days. Ovulation was documented. Endometrium was optimum. It's now 7 years since she started to try. So what next? How will you proceed further in this case, ma'am? Dr. Sita, ma'am? Yes, Dr. Aruna, ma'am?
It's a case of multiple IUI failure.
Yes, ma'am.
There are so many causes for IUI failure. Probably female factor or maybe a male factor, or it may be a lab factor also. For an IUI, lab should be clean. It's a clean room with laminar flow, all these things, because air quality makes a lot of difference. Even time to IUI is also important. After washing, we should finish the IUI within 80 minutes. Otherwise, all the sperms will get capacitated. The other factors are indication for the IUI should be the correct indication leads to successful IUI. Ovarian reserve, all these things also matter.
Yes, ma'am. Thank you, ma'am.
Raised DFI is another factor. Even male factor is normal. Raised DFI or morphology, if it is poor, then it may lead to failed IUI.
Okay, ma'am. So she was further evaluated. Her AMH was 8.6. Rest of the hormonal profile were normal. Vitamin D was 24.6. And then she underwent a hysterolab in 2018. On hysteroscopy, cavity was normal. In laparoscopy, bilateral ovarian drilling was done. Tubes were patent on CPT. So male partner evaluation was done, 36-year-old, BMI of 27, no other risk factors, count being 23.6 million, motility is 37% rapidly motile, and normal forms being 11%. Then the story continues. She then underwent 2 more cycles of IUI with oral ovulogens and gonadotrophins. Ovulation was documented in each IUI, and semen post-process, the count being 20 million per ml, and total motility was 60 to 70%. So how many cycles are justified? What is your opinion, Dr. Durga ma'am?
Frankly, I think this is a $1 million question. And when we are talking about the number of IUIs that are required, if done well, and the points that Dr. Aruna actually said is something that most of us tend to miss. So I think she's really brought out, fantastic points that we have to keep in mind when we are doing an IUI. Aside that, when we are talking about the number of cycles of IUI that are required, we tend to see that after 3 or 4 cycles of IUI, when done properly, that means that she has developed a dominant follicle, ovulated, the total motile count that is being inseminated is more than 10 million, patent, at least 1 patent tube, then after 3 or 4 cycles of IUI, you tend to plateau.
Yes, ma'am.
And when the reserve is good, you may go up to 6, but I think the results after the 4th cycle are going to be similar for the next 2 or 3 cycles.
Okay. Thank you, ma'am.
Recently, I have heard someone saying we can go up to 8 cycles. There is no limit. I mean, as it is, it should not be limited.
So this is where, again, we have to discuss, madam, as to how many times you're giving her fertility medications. Because one thing is clear, when we are giving them Clomid or anything, we are not supposed to go beyond 12 cycles. So I think we also have to consider that if she's not getting pregnant with IUI, she will need IVF, which obviously is going to extend her treatment history. So, but your point is also right in the sense there is no limit, but after 3 or 4 cycles, we have seen more of a
The success rate comes down.
Yeah, as ma'am told, even the literature says nice fertility guidelines up to 6 IUI cycles. And even this review literature also says at least 3 consecutive IUI cycles should be performed. It is of moderate quality evidence. And number of IUI cycles we can see in this picture, the cumulative pregnancy rate and live birth rate, it is increased in first 3 cycles and then it plateaus. So to conclude, less than 35 years with good reserve, 4 to 6 cycles IUI. More than 35 years with average reserve, 2 to 3 cycles IUI. And more than 35 years with poor reserve, IVF. So role of lap ovarian drilling. What is your opinion, Dr. Aruna ma'am?
It's not the first line of management.
Yes,
it's
ma'am.
actually second line of management in case of PCOS. We are supposed to do lap ovarian drilling only in 5 cases, in 5 indications. If the patient is unable to come for regular follow-up, if she is far away from towns, then we can go for lap drilling. The other indication is persistent raised LH. The other indications, if she has any other associated tubal pathology, suspected endometriosis, any pelvic pathology, then we can go for lap drilling. These are the indications. Out of the box indications are raised very high AMH.
Yes, ma'am.
If she has conceived for first time with LOD, then we can go for second time. But it's all these indications are the out of box indications.
As ma'am correctly told, these are
She's
the
not responding to ovulation induction. And
Yes,
if you
ma'am.
think you have to
CC
give her
resistance.
gonadotropins, then it's better to go for when she cannot afford the follow-up, then probably ovarian drilling is a better thing.
Thank you, ma'am. Just to brush up for the PGs, it is for them, for their benefit sake. Advantages of LOD being spontaneous monoovulation. It is as effective as gonadotropins, requires less intensive monitoring. There is no risk of OHSS and no increased risk of multiple pregnancy. The disadvantages being the iatrogenic additions and decrease in ovarian reserve. So one should be cautious during lap ovarian drilling. Rule of 4 to be followed. 4 punches per ovary, each for 4 seconds with 40 watts power setting.
One
So-
important thing I wanted to ask, see, laparoscopy drilling is not a permanent solution, and actually it can recur. See, so many times you do the drilling, 6 months later you feel the same thing. So should we say that this is a temporary thing? Drilling has got sometimes only a temporary effect.
In fact, I think, like Madam was saying, the indication and the patient selection is most important. So if you have a thin patient, not an obese patient, if you have a thin patient, if you have a patient with raised LH, and she should not be hyperandrogenic, these are the ones who will respond to drilling better. So I think patient selection is the first step. And the second step is, if we do not follow that rule of 4, we are likely going to push her from somebody who's over responsive to actually under responsive. So I think the what you're doing, why you're doing it, and how you're doing it is important.
So subclinical hypothyroidism, since she is hypothyroid on medication since many years, what is your take, Dr. Sita ma'am?
If she is hypothyroid, definitely we have to treat it. Because see, one thing is pregnancy, the most important complication is in the fetus. See, that is for sure. Neuropsychiatric development in the fetus is going to be affected. So all patients with subclinical hypothyroidism have to be treated. But another important thing is, see, hypothyroid itself is a cause for so many problems, menstrual abnormalities, anovulation. So I think we should treat all patients with subclinical hypothyroidism before we go for treatment for infertility.
Yes, as ma'am correctly told, subclinical hypothyroidism, it causes menstrual irregularities, anovulation, infertility, miscarriage. In pregnancy, it's being abruption, preeclampsia, preterm labor. In fetus, abnormal cognitive function, neurodevelopmental delay, low IQ, and low birth weight. So 2021 European Thyroid Association guidelines on thyroid disorders with thyroid autoimmunity, either it can be thyroglobulin or anti-TPO antibodies. If the levels are more than 4, either thyroid autoimmunity is positive or negative, levothyroxine therapy is recommended. And when there are suboptimal levels between 2.5 to 4 and thyroid autoimmunity is present, definitely levothyroxine therapy should be recommended. And before we start the ovarian stimulation, the patients who are already being treated with levothyroxine therapy, we should be cautious, like TSH level should be less than 2.5. Why is it so important? Because during ovarian stimulation, there are raised levels of estrogen, and that will cause increase in TRH, and that will lead to increase in TSH. So always before starting the stimulation, the level should be less than 2.5. And even once the patient is pregnant, at the time of UPT positive, subclinical hypothyroid patients, we must be ensured that the TSH levels are less than 2.5.
What about anti-TPO antibodies? Should we do for all patients? Does it indicate that this patient may have later on go into low
Correct,
ovarian
madam. I
reserve?
think it is
Low ovarian
This is
reserve,
very
yes, ma'am.
important because once you do it, you know that she has antibodies. She may have ovarian antibodies also.
Yes, ma'am. Very
That
important
probab-
point, ma'am. Anti-TPO antibodies, we should be very cautious regarding the ovarian reserve, because after 3 or 4 years, she might land up in low ovarian reserve.
And also, if you have raised TPO antibodies, madam, I think the frequency of monitoring, even though she is in the euthyroid state now, later on she might get hypothyroid. So the frequency of monitoring should be lesser, at least every 3 months, so that you can catch them early before they become hypothyroid and have the sequelae that Dr. Vijayalakshmi is talking.
Role of vitamin D in PCOS. What are your inputs, Dr. Aruna, ma'am?
Vitamin D deficiency is associated with hyperinsulinemia
Yes, ma'am.
and hyperlipidemia. So, and it is also associated with type 2 diabetes.
Yes, ma'am.
So, it may lead to poor quality eggs
Yes,
because of chronic inflammatory status in the ovary. It may decrease the chance of pregnancy.
Yes,
See,
ma'am.
vitamin D deficiency always, it's something like it's insulin insensitivity. It causes
Yes, ma'am.
insulin insensitivity.
It causes
And
insulin
also,
resistance.
whatever you have in PCOS, we have a chronic inflammatory state, cytokine-induced inflammation. That also will be suppressed by giving vitamin D. So you should never allow a patient to have vitamin D deficiency. Whichever case it may be, PCO, it is very, very important because it will be actually accelerating the process.
Yes,
That
ma'am.
is why it is very important to supplement.
Yes,
Only
ma'am.
thing is how to supplement it. What is your opinion?
Supplementation of 60,000 units, weekly ones for 8 weeks, later on monthly ones for 6 months.
But somewhere I read it's 1,000 units per or 800. Daily dosing is supposed to be better than a weekly dose because it is going to increase the absorption and also maintain the levels, especially when you are doing before you go for a IVF.
Yes, ma'am. When there is insufficiency, means when the levels are less than 30, it is better to supplement weekly once. Once the levels are reached more than 30, then we can give daily dosage of
Daily
2,000 international units per day. So role of vitamin D, it causes hyperandrogenemia, insulin resistance, as rightly told by Sita madam and Aruna Kumari madam. This all lead to ovulatory dysfunction, and they also lead to abnormal folliculogenesis by formation of reactive oxygen species and accumulation of pro-inflammatory advanced glycation end products. So this review article also says that vitamin D supplementation every other week for 8 weeks definitely had beneficial effects on insulin metabolism and lipid profile of infertile women with PCOS who are candidates for IVF. So the story continues. Till now, like she underwent multiple cycles of OITI and then later on 6 cycles of IUI and lap ovarian drilling was done. She underwent 1 cycle IVF in 2019. It was an ANTAC protocol. 9 days of stimulation was given. 18 oocytes were retrieved, in which 18 were mature. ICSI was done. 18 fertilized and 18 cleaved. Day 3, 11 grade C embryos all have been discarded. There were no embryos available for the transfer. So course at Oasis, we evaluated the male and the female. The FSH was 5.57, AMH was 5.14, and GTT was within normal limits on scan. Right side 8 to 10 AFC and left side 8 to 10. In male, the count was 30 million, motility was 15% and 2% normal forms. DFI was 48%, which was high. Sir, Krishna sir, what causes high DFI? In whom to check it? And how to go about managing high DFI?
So what can cause high DFI? I think anything can cause high DFI.
Yes, sir.
In the present scenario, I think pollution, all the lifestyle-induced factors. I think that, again, reiterates and, we need to take history and examination for every male partner. We do so much for the female partner, but all that we want is man to just give a semen sample. That was the way we practiced in the past. So now I think the man also needs a detailed history, lifestyle management, thorough clinical examination, because there's so much that it can tell us and connect us and help us manage optimally. So raised DFI can be lifestyle-induced, smoking, alcohol, obesity, any systemic involvement, uncontrolled diabetes, hypertension, they also can raise the DFI, or the local causes. The genital tract infections and varicocele are true treatable causes that we would say. In whom to check, again, I think there is quite a bit of controversy. Neither the ASRM or ASHRAE at this point have given out any guidelines for good practice. But looking at certain meta-analysis and few papers published, I think multiple failed IUIs. But how many cycles, again, is a matter of debate. Because, I was saying we can go up to 8 cycles. So is it after 8 that we want to do a DFI, or after 3 is a matter that is debating? And why are we worried? In a individual multiple failed IUIs, the case that we just saw. Because if somebody has had just 2 failed IUIs and I get the DNA testing done and it comes back as raised, you have to intervene. Lifestyle management, antioxidants, to what extent they're going to be efficient, And what is the percentage of improvement in pregnancy and childbirth? Again, we do not know. So if it, after 1 or 2 cycles, I get a DFI testing done, and if it comes back raised, I'm pushing the patient towards a bigger intervention at times, and it gets very difficult in a clinical practice to convince a patient for that. So I might reserve my thoughts with a multiple failed IUI. But I would be very interested and keen to get a DFI testing for somebody with 1 failed IVF or a recurrent implantation failure, recurrent pregnancy loss, where it's idiopathic. From the female side, everything is fine. From the male side, raised DFI can be one of the reasons for the RPL. So I think these are the indications which should be followed. Last point, have we reached a point where a DNA testing is a regular norm with a basic semen analysis? Should everybody along with the semen analysis get a DFI testing
It's
done?
my argument, because you are a male. The female undergoes all the tests under the sky, but the male, he can't even undergo a DFI. What he needs is just an abstinence of 3 days and go for the test.
Absolutely.
So why can't we do it for each and every male patient? Even when the semen parameters are normal. See, the other alternative is giving everyone a course of antibiotic and antioxidants.
Yes.
Whoever goes for it. But then, when there is no proof.
Yes.
So you really do not know what to answer them.
Perfect.
So that's why it's better to do for each and every male patient. That would be my argument,
All right. So the way I would want to, again, I think Madam is right in putting across her points. But again, and I tell them all of that, they go back home, they're wanting to get their finance taken care of, and they come back with a natural pregnancy. How do I justify? I have strongly said that your DFI is really bad, you will need ICSI, and she comes back the very next cycle with a positive UPT. So I think we need to take it with a pinch of salt. Lot of meta-analysis wanting to look at the role of routine testing of DFI for every male partner. Right now, the answer is no. I think we're still multiple failed IUIs, IVF, RPL. I think are the only 3 indications. Now, how do we solve it in an Indian scenario? Because, I'm sure all of us are reading about DFI. So how do we go about with that? So I think this is more of a tool to counsel. You also need to understand, is there a female factor where they need IVF and they're not really wanting to go towards it? You will have to counsel the patient because you do not want to take back your own words. If you can be careful with that, you want to get it done routinely. I don't know how far it's going to add clinical value, but I would not recommend doing it, and we don't do it in our practice.
And the 4th indication would be somebody like her who's had a poor outcome in the previous cycles where the embryological parameters were not met.
Yeah.
But coming to madams and a little support from our end also, madam, is that, raised DFI, you're right, they might get pregnant naturally also, but there is evidence to say that there's a higher risk of miscarriages. That is being...
Yeah, absolutely, ma'am. I think so. How do you manage? I think that's the bigger question. Testing DFI for everybody, I think it should not be a difficult thing in the year 2022 now. It's very easily accessible. In fact, there are commercial kits where we can do it in our own andrology labs. We don't have to send it anywhere else. So what assay you do is very important. Just a staining method and you're seeing a 80% fragmentation, you're not really getting the right picture. So the gold standard is tunnel assay, not again easily available. The next is doing a flow cytometric sperm chromatin structural assay. I think you really need to know which assay was followed and what is the value. 15% and less, it is normal. 30% and above is really raised, and that is when interventions are advised. And we have no answer which is the right intervention. So you could do things for man. So you treat the cause, control diabetes, lose weight, lifestyle management, or if there is a clinically palpable varicocele, then again we probably want to do a surgery. But be very careful to tell your patient, this probably looks like a reason, but I'll operate. At the end, if you don't improve, we can't give any guarantees. That's very important to counsel the patient that a varicose surgery is not a magical thing to get your DFI normal. So treat the cause. Or nowadays, antioxidants, I think you can go ahead. Though the evidence is low to very low evidence to improve live birth rates, the pregnancy rates can improve, is the latest Cochrane Review's summary or conclusion. So antioxidants can be tried. Frequent ejaculation. I think where the whole problem is increasing, at least in the urban population, no time for frequent sexual intercourse. And infrequent ejaculation can be one of the reasons why DFI is going up. So a simple counseling for frequent ejaculation or intercourse is going to help them to an extent, or doing a testicular sperm aspiration. Time and again, we've only thought TISA is for non-obstructive azoospermia or azoospermia in general. But a newer indication, if you have raised DFI, pick the testicular sperm through surgical intervention. And there are a lot of reports which say that at the testicular level, the sperm's DNA is going to be the best. So that's with it. But there are a lot of newer methods of sperm processing. Currently at Oasis, we do a lot of research on this. And at the recent ESHRE, we had 9 abstracts, which were all published on various sperm selection methods with sperm DNA fragmentation. There's MAX, which is magnetic cell separation, and microfluidics. They seem to be kind of working well, but again, not enough meta-analysis or guidelines from any professional body saying that they are the best methods. So you'll have to pick and choose. DFI is a problem, will be detrimental. You need to counsel properly and look for an intervention that would work best for you.
Thank you, sir. So why we are worried about this DFI? It causes fertilization failure, poor embryo quality, as we have seen in this case, implantation defects, spontaneous abortion, and congenital malformation. Rest, all other points have been covered by Dr. Krishna Chaitanya, sir. The best sperm selection methods in managing high DFI, what we are doing at Oasis is microfluidics and MAX. So course at Oasis, a patient was given CoQ and vitamin D3 and tab metformin 1 gram pre-treatment for 6 weeks. Antac protocol was given. Stimulation was started with recombinant FSH 150 and HMG 75. For 11 days duration, growth hormone was added, and dual trigger was given. OPU was done 35 hours later. Microfluidics was done on fresh ejaculate, 32 million, 70% rapid, 10% slow. Husband was given antioxidants for 2 months and was advised daily ejaculate for last 10 days as his DFI was more. So expected were 16, retrieved 8, 17 mature, 15 fertilized. Oocyte quality was dark with large perivitline space and debris. On day 3, 13 embryos obtained and 2 embryos frozen on day 3. All other embryos cultured to day 5. 1 blast, 3 AB grade 3 obtained and frozen. The FET cycle is ongoing. So, role of growth hormone in PCOS. What are your inputs, Dr. Aruna ma'am?
Actually, I have used growth hormone in newer cases, but not in PCOS. I don't know actually.
Okay, ma'am. Actually, the growth hormone, it causes activation of PI3 or AKT signaling pathway. It reduces the apoptosis, protects the granulosa cells from oxidative stress injury. It improves oocyte quality and IVF outcome. The dose being 4 units to 12 units during the stimulation phase, or it can be given 10 days prior to the stimulation. Even from the luteal phase also can be started. The only one person is
PCOS and even poor ovarian
responders also we can give growth hormone, ma'am. Yes, ma'am. Only concern is like cost factor to the patient. So any particular pre-treatments in PCOS, Dr. Sita, ma'am?
I wanted to ask about myonestrols. I would like to use them, I thought they do work well. I don't know
You're right.
your
I mean, when we're
experience.
talking about pre-treatment, the first thing is lifestyle. That is something that has to be mentioned, and weight loss, at least even if you do not give them an unhealthy or probably unrealistic target of getting their BMI less than 28, which is unlikely to happen when you have a 35-year, BMI woman. So the dictum is that they have to lose at least 5% to 10% of their body weight. Start small and then they will build up. So even if they reduce that 5% of their body weight, you're actually changing the metabolism, your hyperandrogenism is decreasing, your insulin resistance also decrease. So that's the first caveat. Second is put them on metformin. The third thing is, yes, vitamin D has to be looked at and corrected. And CoQ is an extremely important and quality changing antioxidant, which has been proven. Melatonin also is catching up with CoQ in terms of being a good antioxidant. Myo-inositol, there's a lot of evidence, yes, but I think recommendations are still being awaited, but a lot of evidence to say that myo-inositol, not just for PCOS, but even for low reserve and poor quality oocytes, is helping in terms of the quality. So more to look forward to regarding inosytols.
So pre-treatment in PCOS, definitely it improves the weight loss, regularizes the menstrual abnormalities, improves the ovulation, improves the glucose intolerance, and also improves the lipid profile and inflammatory markers. So metformin is indicated in PCOS with type 2 diabetes, PCOS with impaired glucose tolerance, who have failed lifestyle modifications, adjuvant therapy to prevent OHSS in IVF, in adolescents mainly to treat impaired glucose tolerance and metabolic syndrome, and in cases of gestational diabetes, and in those who have the family history of diabetes. It is started with low dose of 500 mg once daily and then increased to 1500 to 1700 milligram as the tolerance allows.
So I want to add one point here.
Yes, ma'am.
Exercise helps even in lean PCOS patients.
Yes, ma'am, definitely.
Not only in obese PCOS, even in lean PCOS patients, exercise helps a lot.
Yes, ma'am. So even the evidence says that there is reduction in OHSS rate, increase in clinical pregnancy rate, and in live birth rate, it is of possible benefit, but it is of low quality evidence. So the myo-inositol, this review article says that myo-inositol at a dose of 4 gram per day, 3 months prior to ovarian stimulation, it is effective in normalizing the ovarian function, improving oocyte and embryo quality in PCOS. As Durga ma'am told, however, large multi-centric randomized control trials are needed to assess the clinical pregnancy and live birth rates in ART. So, ma'am, what could have been done differently in this case, ma'am?
I think, and the antioxidants that we just spoke about, preparing the woman, because it was the oocyte quality as well as the DFI that have led to the poor outcome. Whether we should have considered TISA to improve the outcomes better is one thing that, can be considered. Looking that we did microfluidics, but still the outcome, even though it wasn't a failed fertilization, we did end up with embryos. That is, you had 2 day 3 and 1 day
2 day 3 and 1
day 6. So frankly, for a young woman like that, with so many oocytes, it's still not the best outcome. So a question of whether TISA would have made her options better or better embryological parameters is one thing that, could be considered, I think.
Any role of IVM, ma'am?
Definitely role of IVM, but again, here we also have to look at the male factor. IVM is only when we are talking about the woman, wherein we suspect that gonadotropins and sometimes PCO women need prolonged treatments with gonadotropins, and that's when it might have an impact on oocyte quality. So IVM might mitigate those concerns that we have, but it is not going to help you in terms of the FI. So I think IVF would the best chance, but whether TISA would have helped is
okay, ma'am. Thank you. So to conclude, the take-home message, it's not the quantity, but the quality that matters. Protocols should be individualized. Consider checking DFI in cases of unexplained infertility, RIF, RPL, smokers, obesity, varicocele. Male parameters to be monitored more closely. We'll move on to the second case. Mrs. N, 32-year-old, married to Mr. R, 37 years, married for 7 years, secondary infertility with BMI of 27. Menstrual cycles are regular, known case of hypothyroid on medication. First pregnancy, it was a spontaneous conception, 6 years back, twins, male and female child. Male child expired after 2 years of birth. Tubal sterilization was done 6 months post-delivery. Tubal recanalization done 4 years back. But post-surgery, HSG showed bilateral tubal block. So immediate postpartum tubal sterilization. Your thoughts, Dr. Sita ma'am?
You should never do a postpartum tubal, especially when it's a case of twins.
Yes,
whoever
ma'am.
it is, we should not do it. We should wait for 1 year and then plan a sterilization if the patient needs it.
Tubal recanalization versus IVF. Dr. Arunakumari ma'am, your inputs.
Experts in tubal recanalization should be available for us
Yes,
to
ma'am.
do tubal recanalization. IVF is simple and easy when compared to tubal recanalization, and the success rate is equal to both.
Yes,
The
ma'am.
thing is, affordability and failure in IVF, that's also very important. Not that every cycle of IVF is successful. But in case the patient has got a good ovarian reserve,
Yes, ma'am.
and if you think that the recanalization can be done easily, I think we can still opt for tubal recanalization if the patient wants to. Telling her everything about ectopic pregnancy.
Yes, ma'am.
Because recently I had one patient done by Dr. Anantalakshmi, Ritika Hospital, Dr. Anantalakshmi. She came with intrauterine pregnancy. I was so happy,
Yes,
During the
ma'am.
COVID time, Dr. Anantalakshmi had done it. And she
Yes,
came with the intrauterine. So it's not that it is going to give a negative result always, but then still in our setup, I feel if the ovarian reserve is good, that's one important thing, because another surgery is definitely going to drastically bring down the ovarian reserve.
Yes, ma'am. Definitely we have to look
And
for
if the patient is young,
Yes,
a
ma'am.
young patient with a good ovarian reserve, probably you might go for it.
Yes, ma'am. So the role of tubal surgery in the era of ART, it's a ASRM committee opinion. So patient age, ovarian reserve, at the same time male partner also should be evaluated. If male parameters are low, if it is an indication for IVF, definitely we should not go for tubal recanalization. And the technique which was used to perform the sterilization, the expenses, and the other prognostic factors being the tubal length, which should be at least 4 centimeter, and the site of tubal reapproximation, that is isthmo-isthmic reversals have the greater success, and rate of ectopic pregnancy, this should be explained to the couple. It is 4 to 8% in tubal recanalization versus 1.4% in IVF. And women who elect tubal anastomosis, they require early surveillance with the occurrence of positive pregnancy test. If no pregnancy occurs after 6 months, assessment of tubal patency is suggested. So past investigations, her FSH was on higher side, 9.22. Rest investigations were normal. She underwent one cycle IVF in Jan 2022. No reports were available. It was probably a long protocol. And a frozen embryo transfer was done. It was a down-regulated HRT. On day 14, 3 8-cell grade A transfer was done. Beta HCG is 159. It was a biochemical pregnancy. Male partner, 37-year-old. Semen analysis was 15 million with 5% progressive motility and 1% normal forms. And on the USG scrotum, there was bilateral varicocele with DFI of 35%. So, sir, do we routinely advise varicocele surgery?
The answer is no.
Yes.
So I think, rather than discussing where to operate, where not to operate, probably is going to be easier thing to remember. So if there is, a reason where natural conception is not possible because of a female factor, again, I might not be very keen in doing the varicocele surgery. Isolated teratospermia. I think, the moment we see teratospermia 1%, 2%, 3%, we correlate it to varicocelectomy and we want to operate the person. Again, it might not make a huge difference. And subclinical varicoceles. So these three things, the answer is a big no.
Yes, sir.
The other things I think we will have to counsel, because I think, there was a point 10 years back where we suddenly started to believe that varicocele was obsolete. We shouldn't operate. But again, with the DFI concept coming up, I think the role of varicocele is definitely there in infertile patients. Especially if there's an azoospermic male, and if there is a clinically palpable varicocele, we have seen doing a varicocelectomy has improved the chance of having sperms either in the ejaculate or having a positive surgical retrieval has increased. In fact, the meta-analysis by Sandro Esteves, who's done the largest meta-analysis, it says there's almost a 30% chance of having sperms in the ejaculate for a non-obstructive NOA, that's non-obstructive azoospermia man who had a clinically palpable varicocele. So there is a role, but I think we need to take it with a pinch of salt. Always freeze a semen sample before you do a varicocele surgery. Now that cryopreservation is something that's available easily everywhere. Explain to the patient that it is not magical in 100%. The chance of failure, recurrence will always be there. Otherwise, I think people are not going to take us for granted in the present scenario where there's so much of Google knowledge for them. I think that's how I would want to deal a varicocele scenario.
Yes, sir. Thank you, sir. So, surgical varicocelectomy, it should be considered in men attempting to conceive who have palpable varicocele, known infertility and abnormal semen parameters, except for azoospermic man. And clinicians should not recommend varicocelectomy for men with non-palpable varicoceles that detected solely by imaging. And reduce preoperative testicular volume, elevated serum FSH levels, diminished testosterone concentration, and subclinical varicocele are the negative predictors for fertility improvement after surgery. And conservative management of varicocele is recommended when there is no clear indication for varicocelectomy, along with regular follow-up semen analysis and hormonal profile for early detection of deterioration in the testicular functions. So when we investigated her, her ovarian reserve was reduced. AMH was 0.779, and on scan, the antral follicle count on right side it was 4, left side it was 2 to 3. There was an endometrium of 2.5 to 3 centimeter in the left ovary. So, Dr. Durga ma'am, do we advise all endometriotic cysts need to be operated?
The answer is no, which is why, initially in my talk also I was saying that the indications for surgery, frankly, when we are talking about an infertile woman, the indications seem to be coming down drastically. And what we have understood is that not all endometriotic cysts need to be operated. They should be operated only if the woman has symptoms. I think first we have to treat the patient rather than just look at the infertility aspect. So if she's got symptoms which is reducing her quality of life, then it needs to be addressed. That's the first thing. And the second thing is, if you considering IVF, and if the cyst is going to be a deterrent for the ovum pickup, or it's going to make your follicles inaccessible, that's when in ART we would consider doing a cystectomy. Otherwise, if there is no, frankly, there are no guidelines which tells you about which size you actually need surgery or not. But you should also remember, it is not just about ART. If this woman is going to conceive tomorrow, and if the cyst is likely to cause problem in pregnancy, also is something that you might have to anticipate. But the timing of the surgery is also important. You don't need to do it before IVF. Because we know that cystectomy, particularly in endometriotic cystectomy, because there's a lot of pathology and a lot of inflammation there, and it's not easy to peel it like how you would do with a dermoid cyst or otherwise. There's very likely that you're going to remove even some normal ovarian tissue when you're doing cystectomy, and there does reduce your AMH levels of the reserve at least by 20 to 30% post a cystectomy. So if she's got a good reserve or a low reserve, it's best to create the embryos cryopreserve them and then look at treating the disease of endometriosis.
Excision versus drainage. What are your thoughts, Sita ma'am?
Excision, always excision.
Yes, ma'am. And so as ma'am correctly told, like endometrioma should be operated only when there is pain or inaccessibility of follicles in ART, and excision of endometrioma is strongly recommended in infertile women when there is suspicion of malignancy or when there is potential rupture during pregnancy or torsion of the cyst. So cystectomy is always better, and overall low recurrence risk, high spontaneous post-operative pregnancy rate, but we should be always cautious, look at her ovarian reserve and then decide the plan. So role of adjuvants in poor responders, ma'am. Durga ma'am.
I think there is no magic for poor response. Unfortunately, we haven't reached a stage wherein stem cells, PRP, what are the different things that we are attempting now is actually showing a benefit. But so what we have relied on and what has shown to be of some benefit is, like we spoke about ProQ, melatonin, DHEAS, and I think of the lot, testosterone gel. Even though the transport trial has said that it's not making a difference, there are quite a few flaws in the transport trial in terms of the duration and the dose that was given. So we cannot rely just on that trial to say that, transdermal testosterone doesn't work. There are quite a few studies and RCTs which are also supporting that. So I think these are the different adjuvants that we would look at, and definitely growth hormone. And it is always important to add some LH.
Yes,
when you are doing a stimulation for people with poor response.
Ma'am, any other
Protocol?
Absolutely, madam. In fact, I think the ESHRE guidelines, when it talks about ovulation induction, says that, there is no superior protocol when it comes to ovarian reserve. And I think that, ultra flare, microdose, long protocol.
And what about PRP in
Madam, we are doing PRP, but I haven't seen.
But the evidence says that it is not of any.
Absolutely, and frankly, the personal experience has also been the same. It is an extremely hit and run thing. We really don't know whether it is the natural, changes that you see in AFC that's making the difference, or your PRP.
But so many times it happens, the AFC is just 2 or 3, and patient has a spontaneous conception also.
Correct.
With 1 million semen parameter also, the patient conceives. This is something that we cannot, just comment upon. So, but anyway, I just wanted to know about PRP because people are speaking about it so much.
I still think
Because the evidence says that it is not.
The alternative treatment options in poor ovarian reserve patients other than donor gamete. Just now Durga ma'am told, one is dual stimulation can be done, the other one is lab PRP, but definitely the evidence is low. And the adjuvants being, as ma'am told, CoQ10, there is no difference in cycle cancellation rate or clinical pregnancy rate. And DHEA, there is increase in live birth rate, but it is of moderate quality evidence. The testosterone gel, increase in oocytes retrieved, number of embryos transferred, increase in clinical pregnancy rate. There is increase in live birth rate, but it is of moderate quality. And growth hormone, it increases the oocyte retrieval. It increases the number of oocytes for retrieval and decrease the dosage of gonadotropins, increase in clinical pregnancy rate. When it comes to live birth rate, there is an increase in live birth rate, but it is of very low quality evidence. So treatment course at Oasis, we had given pre-treatment for the female partner, CoQ 300, vitamin D3, DHEA for a month prior to IVF cycle, testosterone gel 1 puff per day, that is 12.5 milligram per day, transdermal route for 21 days from day 5 to day 25 prior to IVF cycle. For husband, antioxidants were given. It was an ANTAC protocol, started with clomiphene 100 mg for 5 days, and then HMG 300 units were given, and along with that growth hormone was given. Total 10 days of stimulation. On the day of trigger, E2 was 2800, dual trigger was planned, and OPU was done 35 hours after trigger injection. Microfluidics was done on the fresh ejaculate. So expected oocytes were 7, 6 were obtained, ICSI done, mature 5, fertilized 5, cleaved 4, and 3-day 5 embryos were frozen. LPDR HRT was done in the frozen embryo transfer, 2-day 5 embryos transferred, and the patient conceived. So the take-home message being, low reserve doesn't mean only donor gametes. Cautious judgment before tubal recanalization. Not all endometriomas need surgical management. Adjuvants may have some role in poor responders, and always be cautious before planning for varicocele surgery. Case 3, this is the last case. I know it's already too late. We'll wind it up fast. Mrs. N, 37-year-old wife, married to Mr. Y, age 42 years, married life of 7 years, secondary infertility, BMI of 30, menstrual cycles are regular, history of 3 IUI cycles, donor failed. First pregnancy was a IVF conception. It was a biochemical pregnancy. The past investigations being AMH was 2.34, rest hormones are within normal limits. In male, semen analysis was 3 million, 1% progressive motility and 1% normal forms. USG scrotum was normal, the impression being severe oats. What other investigations to be done in severe oats, sir?
All right, so first is the hormones. So when do we get the hormones? At least 2 analyses, 3 months apart, which have shown less than 10 million sperm count. FSH, LH, testosterone, estradiol. 4 minimum things. TSH, prolactin can add value because they also can affect. And if there is hypothyroidism, it should be taken care even in the male. So my choice would be to get the entire panel of reproductive hormones. Apart from this, I think genetics has got a role. Anything less than 5 million sperm count. Again, look at multiple reports, just not one report. There is a role to look at karyotyping and Y chromosome deletion, especially Y chromosome deletion. Deletion in the C zone can present like severe oligoacidoteratospermia. A routine Doppler scan is a no-no. A routine truss is a no-no. I think hormones and genetics would be my choice if it is severe oligoacidoteratoma.
Cutoff semen parameters for IUI and IVF, sir?
Provided the female parameters are all normal and unexplained, then I think for an IUI, again, it is after you've processed a sample, in final pellet, what is the total motile sperm concentration that we are able to see, TMSE. A 10 million and above plateaus your success. Anything less than 10 million of totals, this, I think IVF probably is acceptable thing. There are guidelines which say even 5 million TMS is acceptable, but I think most of the publications say 10 million of total motile sperm concentration.
And role of antioxidants in severe oats, sir?
Well, I think, is it a placebo? It's helping, not proven. Really, I wouldn't say it's a data where the level is level 1 and it's going to make a difference. But definitely can be added on because there's so much of lifestyle issues we're all going on, and it will do some amount of benefit. I think I would rather be looking at the hormonal medications here.
Okay, sir. If given for how long, sir?
Any medicines, I think the max is 3 months.
Yes.
If you're not able to do anything in 3 months, then I think we need to keep moving.
because patient will be keep on taking like 1 year, 2 years, they'll be going on moving
Yeah,
from here to
it's
one
time to
gynecologist
change.
to other
It's time to move
gynecologist.
on.
So the normal semen parameters according to WHO 2021, sperm concentration being 16 million, total progressive motility it should be 30%, and normal morphology being 4%. So treatment history, first IVF, no details were available. 11 days stimulation was given, 6 oocytes retrieved, 6 mature. On ICSI, there was a total fertilization failure, no embryos left. Couple was counseled for donor embryos in the same fresh cycle and transferred 2 blasts, and it was a biochemical pregnancy. In second cycle, they underwent donor embryo cycle. They have done the stimulated HRT cycle, and 2 blasts were transferred, and it was a failed cycle. So when she came to Oasis, we evaluated her on doing PV examination. Uterus was 10 weeks size. It was irregular in shape. On scan, we found 2 fibroids, which was one was type 5, that was 4 into 3.5 centimeter, and the other was 3 by 3 centimeter fibroid in the anterior wall, which was just in contact with the endometrium, and 2 to 3 small intramural fibroids in the posterior wall. On 3D scan, there was no indentation of cavity. The fibroid just touching the cavity. AFC on right side, it was 6, left side, it was 7. AMH was 1.8. So, is myomectomy justified in this case? What are your thoughts, Durga ma'am?
If you don't mind, can you just go back to her history? I just wanted to see whether she's had any obstetric mishaps. She's primary infertility?
She is a case of, she had one biochemical pregnancy with first IVF cycle. Then they had transferred 2 good blasts in the same cycle. And then again in the second cycle, she underwent 2 good blasts, ma'am.
So, frankly, she does fall into the category of recurrent implantation failure because she's had 4 embryos transferred,
Yes,
and
ma'am.
no pregnancy has occurred. And the only pathology that we are seeing in terms of her pelvis is the fibroid. But you're saying grade 3, and the size being around
4 into 3.5, one is type 5, ma'am.
I would first say that to me, what would be more important is looking at her AMH and her age, is create the embryos and vitrify them. And if I have more embryos, in the sense, if I have embryos that are suitable for more than one transfer, then I could try, because it is 3 and there is no indentation into the cavity. There's a role for medical management of the fibroid by giving her leupride for at least 3 to 4 months, see whether we are able to shrink it in such a way that from 3, it at least progresses to type 4, and then give her one attempt with the embryos that we have. But if her reserve being low, we are unable to create embryos enough for 2 transfers, then I would say go for myomectomy, so that we are eliminating at least the cause that has been picked up in RIF, and then go for a embryo transfer. The second thing is, at this point, even though we are saying is recurrent implantation failure, we will not consider PGT, because her embryos were really donor embryos rather than self-creation. So, there is no role for PGT in her, but ERA can be considered.
Yes, ma'am. Thank you. So, indications of myomectomy. In your clinical practice, when do you advise myomectomy to infertile patients? Dr. Sita, ma'am?
She has got a implantation failure, recurrent abortions. We'll advise them. If it's a large fibroid, or if you want to do IVF and you think that you have a difficulty in retrieval of oocytes, then we have to go for myomectomy.
Okay, ma'am. Thank you.
Distortion of the pelvis, it's an important factor.
What precautions to be taken intraoperatively? Your inputs, Dr. Aruna, ma'am?
Depends upon the size of the fibroid. If it is less than 5 centimeters and submucosal type or intramural intending into the cavity, then we can go for hysteroscopic myomectomy. If it is more than 5 centimeters or the number of fibroids are more than 3, then we can go for laparoscopic myomectomy or open myomectomy.
Yes, ma'am. Thank you. So the ASRM recommendations is, in asymptomatic women with cavity distorting myomas, myomectomy should be advised. And myomectomy is generally not advised to improve pregnancy outcomes in asymptomatic infertile women with non-cavity distorting myomas. So when should they be removed to improve IVF success? Intramural fibroids in close proximity to the cavity or that cause alterations in the menstrual bleeding warrant removal prior to IVF. Some authors recommend myomectomy only for cases like repeated IVF treatment failure, as our panelists told, fibroid-related obstetric complications, and recurrent miscarriages. So the important points is to choose the patient wisely. Fibroid might not be the sole cause of subfertility. To choose the approach wisely. Definitely a fibroid mapping has to be done prior to the procedure. Do not open the cavity, even if it is open, not to suture the endometrium. Suture the underlying myometrium in layers. Obliterate the dead space. Hematoma necrosis infection will lead to weakening of scar. Best energy source is no energy source for subfertile patients, as told by Durga ma'am even during the septal resection. Always have a look at POD following myomectomy to rule out endometriosis. And fibroids touching cavity with history of RPL, they need to be removed. So male partner, semen analysis, when it was done, it was a azoospermia. But after centrifugation, 2 to 3 sperms were seen hyporphied, which was suggestive of cryptozoospermia. In hormone analysis, the FSH was on higher end. So this was the report. After centrifugation, 2 to 3 sperms were seen in the hyporphied. It is cryptozoospermia. So criteria to label patient as azoospermic, sir?
I think at least 2 semen analysis. Ideally, one spermatogenic cycle is the time lag between 2 analysis. And then if you still, I think the lab has to centrifuge the sample. Even then, if they're not seeing any sperms, that is when it's azoospermia. Otherwise, if you see here, we did see 3 sperms, and that's where we label it as cryptozoospermia. So I think how the lab deals is very important. So is there a role for any kind of HRT here? If you really look again at the guidelines, when your testosterone is normal, there's absolutely no role for any kind of HRT to be given. One very important thing we all need to, we keep hearing this, let's again repeat and understand: no testosterone of any form, oral, gel, injectable, depot, to a man who's not completed his reproductive needs. Hypogonadotropism also, I might first want to give HCG and then add on the gonadotropins. Otherwise, testosterone in any form is a no-no for all the, at least let's say, gynecologists and infertility specialists. Let's take that as a dictum. Clomiphene, letrose, well, there has been evidence which says it improves. You'll have to look at the T/E ratio and go about with it. But your FSH value is something that's going to guide you. Anything less than 10, the prognosis is okay. But anything more than 10, I think the prognosis is not great. So if you have to do a testicular biopsy, do that. Do not give false hope to the patient that 6 months of clomiphene or letrozole is going to make a difference. Especially in this case, testosterone is normal. It's 312. FSH is 10. And if he was azoospermia, I would have just gone first, done a TISA. And wherever you're doing a TISA, again, another dictum, please have a facility to freeze. Speak to an IVF center, an embryologist who can come take this tissue. If sperms are seen, we need to freeze. We can't keep on doing surgical interventions on the testis. In the era where cryopreservation works so well, fresh or frozen TISA, the outcomes are all the same. So doing a trial TISA without a frozen backup, I don't think we're giving the best management to the couple who've come to us. So karyotyping Y chromosome, absolutely yes. The answer is yes. The guidelines say get it done, because the commonest karyotype issue that we're going to pick up is a Klinefelter's. So there can be numerical structural issues which can cause azoospermia. And Y chromosome, it's more of a prognosis for me. If the deletion is in A or B segment, there will not be any spermatogenesis. Even a micro TISA is not going to help them. If it is deletion in the C zone, the probability of getting sperm is almost close to 60%. So it's a very good prognostic indicator. So I think genetics should be done for all men less than 5 million and azoospermia. In the current era where so much of surgical interventions have improved, donor is never the first line of treatment for any azoospermic man. First, take a history examine. That itself will tell you whether it's obstructive or non-obstructive to a greater extent. Very small volume testes, undescended testes, are often missed. For 10 years, they're going around and then we pick up a undescended testis. That's a very, very sad state of affair. So history examination is the first thing. Get their hormones, and there's very minimal role for medical management. I think TISA, or I would say micro-TESI in non-obstructive azoospermia, is catching up. The amount of fibrosis post biopsy is very minimal, and you're searching it under an operative microscope. So the chance of finding dilated tubules and getting this retrieval is better with a microtessy. So if possible, I would probably look at doing a microtessy.
Okay, sir. So course at Oasis, ANTAC protocol was given. Stimulation started with recombinant FSH 225 units and HMG 150. ANTAC was given. Our dual trigger was planned. 10 expected, 8 retrieved, 7 were mature, 5 fertilized, 5 cleaved, 3 day 5 plas were obtained. And she was 37-year-old, so we had advised for PGT and 2 euploid embryos. INO4 was used as there was previous history of total fertilization failure. Causes of total fertilization failure, how to overcome it, Krishna sir?
Right. Causes, very difficult to say because it could be ecosperm. What's more important in a case like this is to help the couple understand that there's no blame game here. Most of the times the first IVF cycle is diagnostic. So it could be a poor quality of the oocyte or sperm. So if at all I come across a case of total failure, apart from the clinical side, I think I would first want to look at the lab. What was the quality control like, pH of the media, incubator functionality, the embryologist's performance in the laboratory to see if something grossly went wrong. Because if the problem is in the lab, we might give very wrong options to our patients. So I think I would want to first look at my lab and embryologist. If everything was okay, the only way to say that is if there are other patients in the lab and that they have done well, it's only this patient having a failure, probably it's the patient. So with the sperm, I might want to get a sperm DNA fragmentation done. With egg, there's not much we can do, but probably in a calcium ionoform.
Okay, sir, thank you. Indications for PGTA, ma'am, Durga ma'am, and what are the success rates?
Indications for PGTA currently, the one that can be recommended is frankly advanced maternal age, because as women grow older after 37, 38, the aneuploidy rates are increasing. So if you want to reduce miscarriages, one, you want to reduce the time to pregnancy. These are the two main indications for PGTA, but cumulative pregnancy rates are not better. The only thing is you are reducing the miscarriage rate and time to pregnancy. The other indications which are not validated yet are RPL and RIF.
Okay, ma'am. Thank you, ma'am. So husband was advised.
Patients coming with repeated abortions saying you do IVF, we may have a. So when she's conceiving spontaneously, there is no need to go for IVF just because she has got a repeated abortion.
The only thing is if a DFI is raised, then possibly we have to consider that.
So, Krishna sir, what specific counseling is advised prior to the TISA in a male partner or to the couple?
I think again, first is indication. We really need to know if it's indicated, and I think the counseling is important to tell them that retrieval cannot be 100% all the times, and if that fails, what is the backup plan? We are nobody to decide what the backup plan should be, and now with cryopreservation being so improved, we can vitrify the oocytes. Donor is not the answer. In fact, donor is my Z option that I would want to consider. If TISA has failed, do they want to vitrify the eggs? Micro TC is an option. So that is where a prior workup is important. Of course, FSH might not exactly tell us the retrieval rates, but at least helps us counsel and guide the patient. So workup is important. History examination. I'll again repeat that. Not examining the male, not taking the history is not accepted.
Sita ma'am, role of testicular biopsy. Your inputs, ma'am.
Never do a testicular biopsy. You have to do because we can do a TISA and because testis is not the same. The structure anatomy is not the same all over the testis. There may be different various areas of spermatogenesis. In some places it is there, and in some places it is not there. If you have taken a chunk of tissue which has spermatogenesis, you have done a permanent loss to that patient. So we should never do a testicular biopsy. Always do a TISA and see that you can.
Okay, ma'am. Thank you, ma'am. So, lap myomectomy and hysteroscopy was done. 2 fibroids removed. Cavity was normal on hysteroscopy. 2 months post myomectomy, 2 small intramural fibroids were seen. So, Lipron depot was given and down-regulated HRT done, and patient conceived. Take-home message being myomectomy not indicated in all fertile patients. Azoospermia, read the semen report. check if centrifugation has been done, and always rule out the spillage. Azoospermia does not mean only donor gametes, and trial TISA with semen freezing backup only. Teamwork makes the dream work. I'm proud to say that I work in an amicable environment. It has got vast experience. It gives opportunity for team to grow as a unit, be it in terms of enhancing knowledge and skills, improving communication skills, raising up to the latest technology, which ultimately results in better clinical outcome of patients. Thank you, dear panelists, and thank you, audience, for patient listening. I request Dr. Durgarao ma'am to hand over the memento to Dr. Sita ma'am. I request Dr. Durga ma'am to hand over the memento to Dr. Aruna Kumari ma'am. I request Dr. Radha Lakshmi ma'am, our Honorable Secretary, to speak few words.
Thank you each and everyone for coming and attending, gracing Vijayalakshmi. So thank you my postgraduates, assistants, associate professors, and professor of Kurnool Medical College, Vishwabharati Medical College, Shantaram Medical College, and outside practitioners coming from all over Kurnool and also from Nanjal, Adoni, Pattikonda, Kodumur, and also Gadwal. So I'm able to see all of them with the smiling faces and gaining knowledge with the help of Oasis people. I thank Durgaji madam for bringing world-class technology to the Kurnool city. And even though she started her Oasis Infertility Center in Hyderabad 2009, lastly, madam recognized it is important to start infertility centers in Kurnool also. Thank you, madam, for bringing world-class technology to our Kurnool. She is pioneer and in research and in vitro maturation. And regarding Vijayalakshmi, she did her MBBS from WIMS Ballari, MD from BJMC Pune, and she did her long-term fellowship at Gunashila Hospital, Rajiv Gandhi University of Medical Sciences. Her thirst for starting her infertility practice with good technology now coming true. I wish you all the best, Vijayalakshmi, and I ask all the OBG practitioners to cooperate with Vijayalakshmi. She is approachable at any time and she is down to earth. Thank you one and all for making this program a grand success. And once again, thank you, Oasis people, Chandu, Ravi, Vijay Lakshmi, and Krishna Chaitanya. Thank you, one and all.
Thank you, ma'am. Ma'am, please stay back on the dais, ma'am. Now it's time to felicitate our own Dr. Durga ma'am, Dr. Krishna Chaitanya sir, and Mr. Sudhakar Jadhav. I request Dr. Pramila ma'am, Dr. Wahida madam, Dr. Jailakshmi madam, Dr. Srirama Prasanna madam, Dr. Pramila madam, Dr. B.T. Sita madam to come over the dais. Dr. Aruna ma'am, please come over. Pramila ma'am, Savitri ma'am, Dr. Sudha ma'am, please come ma'am. Savitri ma'am. Dr. Sri Lakshmi ma'am, please come over the dais.
It's bigger than you, and you are not me. The links that I will go to, the distance in your eyes. Oh no, I've said too much. I set it up. That's me in the corner. That's me in the spotlight, losing my religion, trying to keep up with you, and I don't know if I can do it. Oh no, I've said too much. I haven't said enough. I thought that I heard you laughing. I thought that I heard you sing. I think I thought I saw you try.
Thank you, everyone. Now it's Thanksgiving time. We would like to thank each one of the doctors who are present here, in spite of their busy weekday and haven't taken some time to attend Oasis launch event on this Sunday CME today and making it grand success. I convey my special thanks to KOGS President, Secretary and Treasurer for the kind affiliation. I'm very privileged to moderate today's session along with our academically enriched panelists, Dr. Durga ma'am, Sita ma'am, Krishna Chaitanya sir, Aruna Kumari ma'am. We would also like to extend my thanks to our entire team of Oasis Fertility, starting from our cluster manager, center manager, marketing, BD, operations team, counselor, and entire Oasis team Kurnool, who have been working relentlessly to put this program together over a month now. My sincere thanks to Durga Rao ma'am, Krishna Chaitanya sir, Mr. Sudhakar for taking your precious time despite of your busy schedule. Thank you one and all. Kindly join us for the socials, please.
So I want to tell you all the members of Kurnool Obstetrics Gynaecological Society, there will be a CME on 14th in Suraj Grand by all the fetal medicine specialists of Kurnool, and it will be rewarded with 2 AP Medical Council credit hours, credit points. I request all the members to attend that program and get the points. Thank you. Register in advance.